Hey everybody out there listening. On behalf of the Quality Assurance, Quality Improvement team here at Allegiance Mobile Health, my name is Adam Baer and this is your Medic Minute. In today's Medic Minute, we will discuss bradycardia recognition and treatment in the adult patient, which will include pharmacological interventions as well as transcutaneous pacing. Bradycardia, simply put in our adult patient, is a heart rate of less than 60 beats per minute. While any heart rate less than 60 is considered bradycardia, not every patient we see with bradycardia is unstable and requiring intervention. During this discussion, it's very important that we understand that with these patients, we must treat them and not the monitor. This includes obtaining a full medical history and detailed medication list, which we may find might be contributing to the patient's current presentation. So we have a patient who has a pulse rate below 60. As EMS providers, we now have the task of deciding whether this patient is symptomatic or not. So as we assess this patient and obtain our sample history, we want to first ask, is their heart rate less than 50? And are they showing any signs of inadequate perfusion? This includes if they are altered mental status, pale, cool skin, cyanosis, cap refill greater than 2 seconds, is their systolic less than 90 or is their MAP less than 65? These are all signs and symptoms that we will use to determine our treatment plan for this patient. So let's say that we have a healthy adult patient in front of us with a pulse of 44 and a blood pressure of 122/80. While we are definitely tracking the fact that they are bradycardic, that does not mean that this patient is a candidate for transcutaneous pacing. For this individual, let's place them on a 12 lead and obtain IV access. We can consider a fluid bolus in the hopes of raising their heart rate slightly, but for this patient, let's ensure that we obtain a thorough medical and medication history and monitor for symptomatic bradycardia. Let's now say that we are approached by an older male patient complaining of general weakness and overall just not feeling well. Remember that many of our symptomatic bradycardia patients will present with something other than a complaint of chest pain. A chief complaint of general malaise or weakness should be treated promptly. So as we assess our patient, we find that he has a heart rate of 36, a blood pressure of 84/50, and appears pale and clammy. His spouse reports that this has been going on for about 2 days and has been getting worse. We place this patient on a monitor, confirm the bradycardia, and place the stat pads on him. We can consider analgesia for this individual, but given the vital signs and patient presentation, we're going to go ahead and get the pacer going. Let's go ahead now and watch a video of how to initiate pacing on a Tempus monitor.
Go over how to pace with a Tempus. And just to be clear, I want to make it known that I was not filming this on a live person. A symbio was used to produce this rhythm. Let's say that EMS has a patient that is bradycardic and symptomatic and they need to be paced. Let's go over how we would do that. So specifically with the Tempus, it's not going to let you pace unless you hook up the 3-lead. And the 3-lead is made for the Tempus manual. So you can see me hooking it up there on the left side. And once you've hooked up that specific 3-lead to it, then you can go ahead and go to the start pacer button. And nothing is touchscreen. They want to avoid any accidental shocks. So you see the arrow pointing to the start pacer button. So now I have started the pacer. Now I need to select a rate and current. So I'll click the rate and current button and you'll see that it has a rate plus, a rate minus, a current plus, and a current minus. And you use those buttons to go up or down. I like the rate 70. I'm going to go ahead and leave it right there. And now I'm going to gradually increase my current. So you can see every time I press the current plus button, it does go up by 5. We're looking for a pacer spike up against every QRS complex. So I think I end up getting capture around 75. And depending on what your protocol is, my protocol, I have to go up 10 more once I gain capture. I go up to 85, I believe, and then I stop. So as you can see, it is currently pacing, and obviously this is when you're going to check your mechanical and electrical capture and all of that. But let's say you want to get out of this screen right here. You go and you press that back button at the very bottom. It's going to direct you to a screen where you have the option to exit the pacer, go back to your rate and current, pause it, print it, or go home. And so from there, let's say we exit the pacer altogether. We just press that top button where my thumb is right there. So it takes us out of the pacer altogether, and now you see that slow rhythm again. So let's say we want to start it again. We'll start the pacer, and it's going to pick up where it left off, the current and everything. So now you just press start, and it will start pacing again. And like I said, there is that pause button right there in the center. But that's about all there is to it, guys. Thank you so much for watching, and I will see you in my next Tempus video. Bye!
So as you can see on the screen there, our protocol here at Allegiance is to start the pacer at 60 beats per minute and to increase the current by 20 milliamp increments until electrical capture is achieved. As she pointed out in the video, we then want to confirm capture by assessing for pulses and blood pressure to see if our patient is now hemodynamically stable. As you noticed in the video, this demonstration was done with a Tempus monitor. If you happen to be in an area that is using either a LifePak, Philips HeartStart, or Zoll, please refer to the TraumaSoft portal for pacing demonstration videos for that specific model. A topic that often gets discussed during transcutaneous pacing is premedication. While we do not want to delay electrical therapy, we do want to make sure that our patient is as comfortable as possible during the procedure. If your patient has a systolic blood pressure above 90, per protocol consider giving midazolam 0.1 milligrams per kilogram IN, IM, or IV. Midazolam can be repeated every 5 minutes after that at a dose of 0.05 milligrams per kilogram. Remember that with midazolam, or Versed as many of us know it, it may cause hypotension. An option if using midazolam is to begin pacing and then give the medication once the vitals have hopefully improved. Alternatively, we can consider fentanyl for these patients. We can give 1 microgram per kilogram, IN, IM, or IV, up to a max single dose of 100 micrograms. This dose can be repeated after 10 minutes only after contacting medical control. Recently, ketamine has been gaining a lot of popularity given its analgesic effects without too much risk of lowering the blood pressure. As for now, if you feel that your patient would benefit from ketamine as the drug of choice for analgesia, contact Dr. Hart for guidance. This should be addressed in the upcoming protocols later here in 2022. For ketamine, we will typically dose this at 0.2 milligrams per kilogram up to a max dose of 20 milligrams. The takeaway here is that while we do not want to delay electrical therapy, we do want to alleviate the discomfort that our patients are having. In terms of pharmacological interventions for treating bradycardia, we can consider a few medications. The first is atropine. Atropine works by blocking the parasympathetic activation of the vagus nerve and its effects on the SA and AV nodes. By decreasing this activation, it leads to more rapid firing of both nodes, which causes an increase in heart rate. We can consider giving atropine for heart rates below 50, but we should not delay use of electrical therapy if the patient is truly symptomatic. Our atropine dosing is 1 milligram every 3 to 5 minutes as needed, up to a max dose of 3 milligrams. Also remember that with second degree type 2 or third degree or complete heart blocks, atropine may not be effective since there's a complete disassociation of the nodal firing within the heart. For these patients, while we can still give atropine, a better course of action is to go straight to pacing if they are symptomatic. Within the Allegiance protocol, we can also give norepinephrine at a starting dose of 2 to 4 micrograms per minute IV drip. Per Allegiance Medical Director Dr. Hart, norepinephrine is only preferred as an IV drip, not as a push dose. This will also be addressed in the upcoming protocol changes here in 2022. This can be achieved by taking 4 milligrams of norepinephrine and adding it to a 250 ml bag of normal saline. This will give you a medication concentration of 16 micrograms per ml. If for some reason your truck does not have 250 bags, you can achieve the same medication concentration of 16 micrograms per ml by mixing 8 milligrams of norepinephrine into a 500 ml bag of normal saline. And we will titrate this to a systolic blood pressure of 100. The max dose that we will give of our norepinephrine is 12 micrograms per minute. So one of the things that excites me as a paramedic is that with our bradycardia patients, we really have an opportunity to take a very sick person and make them much better just in the short period of time that we have with them under our care. And the reason that I say that this excites me is that here we get to really put a focus on being clinicians instead of just technicians. There are many things that can make a patient bradycardic. As we noted in the beginning of the video, it is imperative that we are obtaining a detailed medical history and medication list, including any recent dosing changes or new medications. Just about all blood pressure medications can and will affect a patient's heart rate, so let's discuss a few of them. We'll call this treating reversible causes in bradycardia. So first we'll talk about beta blockers. These are medications such as atenolol, metoprolol, bisoprolol, propranolol. Beta blockers work by blocking the actions of epinephrine or adrenaline on the heart. This in turn makes your heart beat more slowly and with less force. If we have a patient that we suspect is experiencing beta blockade, either they took too much or switched medications or what have you, we want to treat them with glucagon. We will give them 1 mg glucagon IV. Next are calcium channel blockers. This is your amlodipine, nicardipine, nifedipine, verapamil, diltiazem, and so on. These work by blocking the calcium channels in the blood vessels and cardiac cells, which in turn prevents calcium from entering the cell and causing excitation. This allows the heart and blood vessels to relax. For these patients, it's pretty straightforward. We need to get calcium into them. We do this by giving 1 gram of calcium chloride slow IV push. One other thing to remember about calcium chloride is that we can also consider it for our patients that we suspect are hyperkalemic. The dosing of 1 gram slow IV push is the same for those patients as well. Lastly, we'll cover sodium channel blockers. These aren't seen as much as calcium channel blockers or beta blockers, but you may still see them from time to time. These are medications such as quinidine or procainamide. Much like how the calcium channel blockers block calcium channels, sodium channel blockers block sodium channels in the heart that are responsible for the rapid depolarization of the cardiac muscle. This too allows for relaxation of the heart muscle and in turn lowers the heart rate and blood pressure. For these individuals, the quickest way to get sodium back into them is by giving sodium bicarb slow IV push at a dose of 1 milliequivalent per kilogram. So to summarize, we've covered quite a lot in a short period of time in regards to bradycardia and its treatments. Remember first and foremost that we are treating our patient, not the monitor. Remember that if we determine that it is symptomatic bradycardia, we can go ahead and give atropine and start transcutaneous pacing if needed. Also, remember to consider premedication for our patients to alleviate discomfort. We don't delay pacing if it's needed, but we do want to get something on board for them if possible to treat any pain. If our patients still need support to raise their heart rate and blood pressure, remember to consider norepinephrine IV drip starting at 2 to 4 micrograms per minute. Look for those reversible signs of bradycardia. We talked about different blood pressure medications that can cause a slowing of the heart. For many of these potential toxicities, we have the antidote on the truck in the form of glucagon, sodium bicarb, or calcium chloride. And lastly, remember that you're not alone on the truck. If you feel that you need a consult, reach out to Dr. Hart to discuss the patient's presentation and treatment options. Our goal at the end of the day is to properly and effectively treat the patient. If you have any further questions, feel free to contact your supervisor or anyone on the quality assurance, quality improvement team at QAQR_team@allmh.com. Once again, thank you for what you do, stay safe, and have a great day.